The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another edition of Inside JACC. And today I have the pleasure of talking to actually one of my great collaborators. Chris Cannon has taken up the position of helping us edit the new JACC edition on the iPad. Chris is well known to everybody, one of the premier members of the TIMI study group at the Brigham and Women's Hospital in Boston, and a senior author of a very interesting paper that we're publishing in JACC that deals with the question of whether or not prior aspirin use actually renders patients with acute coronary syndromes at higher risk of mortality. So, Chris, tell us a little bit about the study.
Sure. Well, part of the debate has been whether someone already on aspirin is a high-risk patient because they required aspirin, or are they an aspirin failure that somehow they're not responding to aspirin in a normal way. And so we merged 16 of the TIMI trials and looked at the outcomes, which were worse for people on prior aspirin, but then we looked at who the people were and adjusted for differences in those baseline characteristics.
So, it's interesting. I've looked at it a little bit differently, that patients who come in with ACS who are already on aspirin perhaps have more severe disease, more malignant disease. In order to determine whether or not the patients were aspirin failures, you would think that you'd probably have to go back and test that specifically to see how their platelets responded to aspirin. Now, as I understand it, you didn't do that in this study.
Right. So here we look just at the first part of that, of do they have worse disease? And in fact, they do. They have more prior MI, higher percentage of risk factors and diabetes and everything. So when we look at the outcomes, we see, not surprisingly, a higher risk of mortality, MI, etc. But then when we adjust for the fact that these people are older and have prior MI, there's then no adjusted difference in their mortality. And so this suggests that for mortality, that it's more of a marker of a high-risk patient that they had already needed to be treated with aspirin, as opposed to something that inherently is saying that they're higher risk and more thrombotic necessarily. There was a slightly higher risk of developing a recurrent MI, but it also was attenuated with the risk factor adjustment. And so we've come away from this thinking that the prior aspirin, that's part of the TIMI risk score and other risk scores often, is more of a marker of a high-risk patient, perfectly useful, but not necessarily a pathobiologic aspect of being an aspirin failure.
Yeah, I think the key was correcting for the risk factors and showing that once you did the multivariable analysis that, in fact, the mortality was no higher in the patients who came in on aspirin. Yeah.
Then the other interesting thing that we have seen in other smaller trials, but saw obviously in this 66,000 patient thing, that there was a benefit of being on aspirin, that the patients presented with a less severe acute coronary syndrome. So of the people on aspirin, there was a higher percentage of unstable angina and then non-STEMI, and the least or a lower percentage of STEMI relative to those patients who had their ACS event de novo. So that's saying that the aspirin is likely doing something, that we would think it's decreasing the thrombosis.
Of course, those patients on aspirin were also on other anti-ischemic drugs, anti-thrombotic drugs, so the combination may have contributed. Very interesting. I think this really puts in perspective this whole issue of the status of patients who are on aspirin but nevertheless go on to have an acute coronary syndrome. Thanks very much for being with us.